Welcome everyone. In this class, we have overviewed the concept of beauty and reviewed the anthropometry and basic and classical facial analysis until now. At this moment, we need to revisit powerfully established tool in our field, the dentistry or orthodontics, the cephalometric analysis. So today's topics are cephalometry and cephalometric analysis. Cephalometry is the scientific measurement of the heads of living individual. Etymologically, the term cephalo is derived from Greek kephale, or head, and the metron means a measure or measurement. Cephalometry radiography is a radiographic technique for measurement of craniofacial complex. It is closely patterned after craniometry, which is scientific measurement of dry skull used in physical anthropology. Cranion is a Greek, which means skull. The use of skull radiographs in craniometry was first pointed out by Pacini in 1922. He demonstrated to anthropologists that accurate cranioskeletal measurements could be made from skull radiographs more easily than from the skull itself. Pacini described the addition of an object of known length to the exposed field and advised the use of known distance from the X-ray source to the skull. The head positioning device, cephalometer or cephalostat, and the technique of radiographic cephalometry were introduced in 1931 by the orthodontist Holly Broadbent in the USA and Herbert Hofrecht in Germany simultaneously but independently of one another. The forerunner to the cephalometer, termed the Reserve Craniostat, after Case Western Reserve University Medical School in Ohio, was developed by English surgeon and anatomist Thomas Wingate Todd after his appointment as professor of anatomy at Case Western Reserve University Medical School in the USA. Broadbent worked with Todd and helped to modify the craniostat to permit precise standardization of cranial radiographs of dry skulls. As a result of his work, Broadbent was assigned to research under Todd the cephalic development of children in a study sponsored by the Brush Foundation, which led to the adaptation of reserve craniostat to permit radiographs of the head of living subjects, hence the development of the röntgenographic cephalometer. The significance of the cephalometric radiography, as opposed to routine skull radiography, was standardization of the technique and reproducibility of the images. The patient is positioned in a cephalometer or cephalostat with ear rod placed as a head-holding device. The distance from the X-ray source to the patient's mid-sagittal plane is fixed. The distance from the mid-sagittal plane to the cassette will be the same of each individual patient. Thus, repeated exposures may be made on successive occasions under standardized conditions. The lateral cephalometric radiograph may be conventionally taken with the patient's right side or left side depending on the country located nearest the film. The posterior anterior cephalometric radiograph is taken with the patient facing the film. Now, let's move on to the cephalometric landmarks and plane of references. The facial surface and the underlying craniofacial skeleton have a large number of reference points and topographic landmarks. An anatomical landmark may be defined as a readily recognizable point that is visible to human eye, but is not divisible into parts, for example, lesion and menton. Alternatively, visual landmarks that represent the intersection of lines are termed constructed landmarks. For example, there is an articulaire. Knowledge of the precise location of the landmarks on cephalometric radiograph is required in order to obtain reliable linear and angular measurements. Points or landmarks joined together continuously in a row form a line. A line may be defined in that its length may be divided into parts, but it is so slender that it cannot be divided in widths. So to speak, the Greek mathematician Euclid wrote, "A line is a length without breadth." An imaginary straight surface on which a group of lines positioned next to one another would lie in term a plane. In Latin, the planum means the flat surface. Planes are, by definition, two-dimensional. In two-dimensional analysis of lateral cephalometric radiographs, some authorities only use term line as transverse and vertical planes in the frontal view are not visible, whereas others use the term plane as a number of cephalometric lines may be thought as planes. For example, the line joining Cellar and Incision, which approximately indicates the anterior cranial base, may be termed an SN line or SN plane. So both terms are acceptable. It is perhaps more important that in analyzing two-dimensional cephalometric radiographs, clinicians think of cephalometric line as a plane in their mind's eye. Specific planes from which the positions of other craniofacial structures are judged are termed planes of reference. A two-dimensional cephalometric radiograph is a two-dimensional visual representation of three-dimensional object, that is to say, the craniofacial complex. Nevertheless, despite this drawback, a thorough understanding of two-dimensional cephalometry and cephalometric analysis has been the prerequisite to understanding the structural relationships of the craniofacial complex. Additionally, the majority of available data from longitudinal growth studies based on two-dimensional cephalometry. Although some of these data is applicable to the three-dimensional model, such as the measurement taken in the mid-sagittal plane, much of the data will not be directly applicable. The advantage of three-dimensional cephalometric images viewed on a computer monitor is that the image may be viewed from multiple perspectives. Analysis of three-dimensional cephalometric images permits the use of solid geometrical analysis as opposed to two-dimensional plane geometric analysis. Therefore, in addition to the linear and angular measurement, volumetric measurement may be also taken by solid geometric analysis. It is important to bear in mind, however, that a thorough understanding of two-dimensional cephalometric analysis is indisputably important for understanding the craniofacial complex and analyzing three-dimensional images. Okay, from now on, we will look into the cephalometric landmarks. There are hard tissue landmarks and soft tissue landmarks. We could divide hard tissue landmarks into skeletal and dental landmarks. And there are landmarks from the lateral and frontal radiograph. The frontal radiograph can be called posterior-anterior radiograph. First, hard tissue lateral cephalometric skeletal landmarks. Glabella, G. Its definition is the most prominent point of the anterior contour of the frontal bone in the mid-sagittal plane, in the supraorbital and frontal sinus region. Incision. It can be abbreviated as N or NA. The definition of incision is the intersection of the intranasal and frontonasal suture in the mid-sagittal plane. Frontonasomaxillary point. This point can be abbreviated as FNM or M point. The definition is the point at the junction of the nasofrontal and nasomaxillary sutures. It is designated as endpoint by the craniofacial surgeon Jean Delaire. It is used to construct the superior cranial baseline by joining endpoint with the apex of the posterior clinoid process, which is abbreviated PCP in the Delaire craniofacial analysis. The next is orbiter, OR. The definition of this point is the lowest point on the inferior orbital rim. Actually, it is a bilateral structure. Anterior nasal spine. It can frequently be called as ANS. The tip of the bony anterior nasal spine. This point corresponds to the anthropological point of the acanthion. A point, or point A, or it can be called as subspinal. The definition of it is the point at the deepest midline concavity on the maxillary alveolus between anterior nasal spine and prosteon. Prosteon, it can be abbreviated as PR, or it can be called as a supradentale. Supradentale can be abbreviated as SD. By definition, this landmark is the most inferior anterior point on the maxillary alveolar process between the maxillary central incisors in the mid-sagittal plane. The next is the infradentale. Briefly, it can be called as ID. Its definition is the most superior anterior point of the mandibular alveolar process between the mandibular central incisors in the mid-sagittal plane. B point, or point B. The other name of it is supramentale. Its definition is the point at the deepest midline concavity on the mandibular alveolus between infradentale and pogonion. D point, or point D. This is the center of the body of the mandibular symphysis, as known as bony chin, in the mid-sagittal plane, and is estimated visually. The angle SND was described by the orthodontist Cecil Steiner to provide an assessment of sagittal position of the mandibular skeletal base in relation to the anterior cranial base. Pogonion. It can be abbreviated as POG. The most anterior point on the contour of the mandibular symphysis in the mid-sagittal plane. Gnathion. GN is the abbreviation. Its definition is the most anterior inferior point on the mandibular symphysis in the mid-sagittal plane. It may be determined by inspection as constructed as the point of intersection of vertical tangent to pogonion and a horizontal tangent to menton, extending the bisector through the anterior-inferior curvature of the mandibular symphysis. Menton. We use ME as abbreviation. Its definition is the most inferior point of the mandibular symphysis in the mid-sagittal plane. Now we have looked over the anterior facial landmarks from superior to inferior. In the next part, we will look over the posterior facial landmark approximately from superior to inferior. The first one is the Cellar Entrance Point, SE. It is the midpoint of the entrance to the Sella Turcica. Sella, S. It is the point representing the geometric center of the pituitary fossa, as known as the Sella Turcica, in the mid-sagittal plane. Posterior clinoid process point. It can be abbreviated as PCP. It is the most superior point on the contours of the posterior clinoid process. The next is Parion, the very famous point, and can be abbreviated as a PO. The anatomical porion is the most superior point of the outline of the external auditory meatus. It is actually bilateral structures. The use of ear load in the cephalostat often makes anatomical porion difficult to locate, in which case the superior margin of the glenoid fossa on the temporomandibular joint that lies at the same level may be substituted for constructing the Frankfurt horizontal plane. The term machine porion refers to the most superior point of the image of the ear rod, which some authorities used as an alternative. Condylion, CO. It is the most posterior superior point on the head of the mandibular condyle. It is also a bilateral landmark. Condylar midpoint, CON. This is the arbitrary center of the mandibular condyle in the lateral view. It is estimated visually. The alternative term is capitulaire. An imaginary line through point CON of both mandibular condyles forms the condylar hinge axis, around which the mandible may rotate during the initial part of the opening movement. The next is the articulaire. The articulaire is abbreviated as AR. It is the point of intersection of the images of the posterior border of mandibular ramus and the inferior border of the basilar part of the occipital bone. It is also a bilateral structure. It may be used as a substitute for condylion if the latter is not readily discernible. Articulaire is often the most superior point of mandibular ramus that can be consistently identified. It was defined by the orthodontist Anne Bjork. Any opening or closing movements of the mandible will alter its position. Bayesian, BA. The most inferior point on anterior margin of the foramen magnum in the mid-sagittal plane. Opistheon, OP. It is the most inferior point on the posterior margin of the foramen magnum in the mid-sagittal plane. Bolton point, BO. It is the highest point on the upward curvature of the outline of the retrocondylar fossa of the occipital bone, approximating the center of the foramen magnum. It is named by the orthodontist B. Holly Broadbent in the honor of the philanthropist Charles B. Bolton. Pterygomaxillaire superius. It can be abbreviated as PTMS. The pterygomaxillary fissure is a bilateral teardrop-shaped area of radiolucency, and the anterior surface of which represents the posterior surface of the maxillary tuberosity. The landmark is the most superior point of the pterygomaxillary fissure. Pterygomaxillaire, PTM. It is the most inferior point at the junction of the anterior and posterior borders of the pterygomaxillary fissure. It is a bilateral landmark, and this point is in very close proximity to PNS. PNS, posterior nasal spine. It is the most posterior point on bony hard palate in the mid-distal plane. It may be located by extending the anterior wall of the pterygomaxillary fissure inferiorly to the intersect the hard palate. GO, gonion. The gonion is the most inferior posterior point on the contour of the angle of the mandible, as known as gonial angle. It may be determined by inspection or constructed as the point of intersection of the posterior ramal plane and mandibular plane, extending the bisector through the curvature of the gonial region of the mandible. Hyoid point, HY. This point is the most anterior superior point on the body of the hyoid bone. It is also termed as hyoidal. Moving on to the next part, hard tissue lateral cephalometric dental landmarks. The first one is centroid. It denotes the center of resistance and can be abbreviated as a CR. The definition is the midpoint of the root axis of the most prominent maxillary incisor. The center of resistance or centroid CR may be defined as the point within a tooth on which the application of a single point force may be produce bodily movement of the tooth. The precise location of the center of resistance of tooth is somewhat contentious issue. Assuming intact periodontal support, the CR of single-rooted tooth such as maxillary central incisor is estimated to be anywhere between 1/3 and 2/3 along the distance between the root apex and the crest of the alveolar bone. Therefore, the midpoint of the root axis of the embedded portion of maxillary central incisor root is an acceptable compromise. The next landmark is the Incision superius apicalis, abbreviated as ISA. The definition is the root apex of the most anterior maxillary central incisor. The next, Incision or Incision superius incisalis, ISI. The tip of the incisor edge of the most labially positioned maxillary central incisor crown. The next is the Incision inferius incisalis. Its short form is the 3I, III. The definition is the tip of the incisor edge of the most labially positioned mandibular central incisor crown. Incision inferius apicalis, IIA. The IIA is the root apex of the most anterior mandibular central incisor. MX6 point MBC. This landmark denotes the mesiobuccal cusp tip of the maxillary first molar crown. MN6 point MBC. It denotes the mesiobuccal cusp tip of the mandibular first molar crown. Okay, moving on to the soft tissue lateral cephalometric landmarks. When writing, for discrimination purpose, we use apostrophe or prime symbol after the landmark names. On the other hand, when we speaking these landmarks, we just add soft tissue anterior to the names of landmark, like soft tissue glabella. Okay, the first one is the soft tissue glabella. It is the most prominent point of the soft tissue anterior contour of the forehead in the mid-sagittal plane. In the supraorbital brow ridge region in the mid-sagittal plane. Soft tissue nasion. Cephalometric soft tissue nasion is usually the point of deepest concavity of the soft tissue contour of the root of the nose in the mid-sagittal plane. Soft tissue nasion and skeletal nasion should be at the same vertical level. In some individuals, there is an anterior curvature of the superior portion of the nasal bones. In such patients, the deepest point of nasal radix is termed salient or subnasion, which is inferior and usually posterior to the soft tissue nasion. Soft tissue rhinian. It is the soft tissue point overlying the caudal end of the nasal bone in lateral view, marking the osseocartilaginous nasal junction. Pronasal, PRN. It is the most prominent point of the nasal tip in the mid-sagittal plane. Subnasal, SN. It is the point where the base of the nasal columella meets the upper lip in the mid-sagittal plane. Soft tissue A point or supralabial. It can be abbreviated as SPL. The definition is the point of greatest concavity of the facial contour of the upper lip between subnasal and labial superiors in the mid-sagittal plane. The next one is a labial superiors, LS. It is the point representing the mucocutaneous vermilion border of the upper lip in the mid-sagittal plane. Stomion superius, STS. It is the most inferior point of upper lip in the mid-sagittal plane. Stomion, ST. ST is the most anterior point of contact between upper and lower lip in the mid-sagittal plane. If the lips are held apart in repose, a superior and inferior stomion point may be distinguished. Stomion inferius, STL. STL is the most superior point of lower lip in the mid-sagittal plane. Labial inferius, LI. LI is the point representing the mucocutaneous vermilion border to the lower lip in the mid-sagittal plane. Soft tissue B point, sublabial. It can be abbreviated as SBL. The SBL point is the point of greatest concavity of the facial contour of lower lip between labial inferius and soft tissue menton. It is the deepest point of the mental labial fold. Soft tissue pogonion. Soft tissue pogonion is the most anterior point on the contour of the soft tissue chin in the mid-sagittal plane. Soft tissue Nephian. It is the most anterior inferior point on the soft tissue chin contour in the mid-sagittal plane. It may be determined by inspection or constructed as the point of intersection of vertical tangent to soft tissue pogonion and horizontal tangent to soft tissue menton, extending the bisector through the anterior-inferior curvature of soft tissue chin pad. Soft tissue menton. This point is the most inferior point of the soft tissue chin in the mid-sagittal plane. Cervical Point, or C. C is the innermost point between the submental region and the anterior surface of the neck in the mid-sagittal plane. It is located at the intersection of a horizontal tangent to the submental plane and a vertical tangent to the anterior neck plane. The next is the hard tissue posterior anterior cephalometric landmarks. Crista galli, CRG, is the most superior point of Crista galli. Anterior nasal spine, ANS, is the center or tip of bony anterior nasal spine. Incision superius frontale, ISF. The ISF is the midpoint contact between the maxillary central incisors at the level of the incisor edge. Incision inferius frontale, IIF. The IIF is the midpoint contact between the mandibular central incisors at the level of the incisor edge. Menton. Menton is the midpoint on the inferior border of the mandibular symphysis. Until this, the 5 landmarks are the midline landmarks. The next is the bilateral landmarks. The first one is Urion, EU. The EU is the most prominent lateral point on the side of the skull in the region of the parietal and temporal bones. It is the most lateral point of the cranium. Lateral orbital, LO. The LO is the intersection of the lateral orbital contour with the innominate line. The innominate line represents the tangentially viewed temporal surface of the greater wing of the sphenoid. Mediorbital. The intersection of the medial orbital contour with the superior contour of the lateral wing of the sphenoid. Zygion, ZY, is the most lateral point on the zygomatic arch. Maxillary, MX. The MX is the intersection of the lateral contour of the maxillary alveolar process and the inferior contour of the zygomatic process of the maxilla. MX6.BS. It is the most prominent lateral point on the buccal surface of the first permanent maxillary molar. MN6.BS. It is the most prominent lateral point on the buccal surface of the first permanent mandibular molar. Mastoideo, MS. MS is the most inferior point of the mastoid process. Mental foramen, MF. The MF is the center of the mental foramen. Gonion, GO. The gonion is the most inferior, posterior, and lateral point at the angle of the mandible. Antegonion, AG. The AG is the most superior point in the antegonal arch. Okay, until now, I have explained to you the almost all cephalometric landmarks. The next time, I will introduce you to the cephalometric reference plane and the cephalometric analysis and its principles. Thanks for watching. See you next week.